Hello, my name is Pam McKlveen, and I am the coordinator of Allegheny Health Network's lung cancer screening program. We are a network of 7 major hospitals in the Western Pennsylvania region. And with the lung screening program, we encompass 14 screening sites throughout our network. With so many sites, coordinated care and multidisciplinary conference is so vital to the role of the lung cancer screening program. Today, I'm going to speak to you on that. Our objective, first, is to identify the purpose of a multidisciplinary conference for lung cancer screening. Then we want to recognize which patients should be presented at the conference, as well as what professionals should be in attendance of that conference as well, and understand the results of using a multidisciplinary conference in a lung screening program. Some of you may already have a lung cancer screening program and are currently using a multidisciplinary committee or conference, but some of you may be looking forward to starting that process into your program. And today I would like to just work with you to address the benefits of having a multidisciplinary conference and how important that is into the lung cancer screening program, particularly if you have multiple sites. The purpose is to provide a consensus recommendation from a panel of specialists for lung cancer screening patients with a suspicious finding. We like to include not only the suspicious findings, which are your lung RADS category 4A, 4B, 4X, we also consider significant thoracic findings as well presented at our conference. By doing this, this gives a guidance to the ordering provider for the treatment of a suspicious finding. So the patients presented, as I said before, are lung RADS category 4A, 4B, and 4X. Also, any lung RAD categories that has the S modifier that is thoracic based. Now, many of you with maybe a smaller facility would like to include the other significant findings, whether it be a renal mass, a breast mass, or coronary artery disease or calcifications that may require a cardiology consult. Some of those cases can be presented as well. We at our network chose just to limit it to the thoracic because our conference is based on a thoracic base due to the large number that we do present each week. Cases are not only viewed by the radiologist reading. Our panel of specialists in our multidisciplinary conference is weekly. We have the radiologist who presents the case. We have pulmonologists as well as a thoracic surgeon. We also have med-onc, rad-onc, and of course, primary care physicians are also invited to attend as well. It provides the best course of care for your patients. By presenting these cases, it gives an overwhelming result to what the next step is for the patient. So by having these group of specialists, they want to see what is the best course of treatment. For example, we look at many category 4A cases in our conference, and a lot of times they are category 4A is either a 3-month follow-up with a CT or a PET scan. Well, by having the multidisciplinary committee, we have found that having those expert panel of physicians looking at these cases, that having them do PETs, they find that is not always the best course of treatment because they look at the size of the nodule, they look at the location of the nodule as well. So in a conference, they may decide, well, you know what, a PET may not be as effective as waiting 3 months to see what the results are. We have done some studies and have found that almost 20% of our patients that are category 4A have a 3-month follow-up, and usually those results do change their category. So they'll go from a category 4A maybe back to a category 2. As I said, it's a case-by-case basis, but they do look at that. They also look at all the other category 4 cases that see where a thoracic may be involved, whether the best course of finding a tissue diagnosis may be through a Navi bronch, through the pulmonologist, or it may in fact be a CT-guided biopsy, or if they do need to go and have a wedge resection or a lobectomy to get a tissue diagnosis. But presenting these gives the primary care physicians and the ordering physicians a sense of knowing that this case was presented, this case was looked at by multiple different specialties, and is giving the best course of treatment. Following the conference, what happens is the radiologist will go back and create an addendum following the conference with the consensus recommendation. The nurse navigator then informs the ordering provider of the multidisciplinary conference results, either via fax, we use Epic, so an Epic messaging system, or a phone call. But they know prior to this multi-specialty conference that their patients were going to be presented. So once you have a suspicious finding, the result, the ordering provider is notified that their patient will be presented at the weekly conference, and the results and recommendations will follow. Many of our physicians really respect the system, knowing that the best course of treatment is for the patient is being looked at. Patients are then mailed the final report with that addendum on, and with all of the multidisciplinary committee recommendations. And then the nurse navigator will then follow the patients to assure that the recommendations are followed through. And it is vital that you keep records of that. We have presented over 160 cases this past year at our multidisciplinary conference. And that allows you to track for not only your ACR information, but also for your program information to find out how many of those cases are then positive, what are the changes of those cases, whether they turn to a category 2 or require other consults. Like I said, we only send the thoracic consults, the thoracic category S patients to the multidisciplinary conference, but if you have a smaller location, a smaller number of patients that are coming through, you may choose to include all of the significant findings just to have records of it being reviewed by the panel of physicians. Multidisciplinary conferences for lung cancer screening category 4A and 4B and X, as well as significant findings, will provide the patients with the consensus recommendation for the findings of their lung cancer screening low-dose CT, thus providing the patients with the assurance that their specific screening was evaluated by a panel of medical specialists.